Okay, good morning, everyone. At the outset, I would like to thank Divya and the KSOS organizers for this opportunity. And I'll be speaking on a pediatric ophthalmologist perspective on the management of congenital lens subluxation, and it's purely my practical experience that I will be discussing. So coming to whenever a child or a young adult, sometimes they come as young adult, they come to us with congenital dislocation, subluxation of the lens. The few things that runs in our mind are what could be the cause for this, and a detailed family history, because many of these runs in families, and the current situation is the thing of the present that we are more bothered about. And if we need any investigations to be done, and the first aim will be for a conservative management, and ultimate will be a surgical one. So coming to the causes, we know there are a number of causes for congenital subluxation, but in my experience, more we have seen of Marfan syndrome. Maybe it is easier to diagnose. Then you have the simple primary ectopia lentis, and the other situations like homocystinuria, Ehlers-Danlos syndrome, we do see, but it is little more rarer. Now, coming to a detailed family history is extremely important, because it is very common to have a mother or a father with the similar physical characteristics, which helps you in the diagnosis, and also you should ask for the consanguinity. So the investigation part, do you need to investigate all the cases? It is not a must that you have to investigate if you have a proper diagnosis. And clinical picture itself gives you a clue. You see a tall mother or father accompany a tall child, then itself you can make a diagnosis. And a detailed systemic evaluation is mainly for academic purpose, and also rule out comorbidities when you are intervening these children. And also a genetic screening if they are planning for extension of their family. So we are more bothered about the current situation, and what can you do in the current situation? That is mainly a refractive status is what decides the vision of the child. So vision of the child is very important, and many of them do come late, especially when it is unilateral. So you can manage them conservatively if there is acceptable vision with correction, and it could be a spectacle or a contact lenses. And the intraocular pressure status is also important, because this abnormal position of the lens can cause an increase in intraocular pressure, and you need a detailed fundus evaluation also, because many a times peripheral fundus examination can be difficult, and there will be associated high myopia in many of these cases, and a poor cooperation of the child and undilating pupil is also common in congenital subluxations. So what are the indications for surgical intervention? So lens-induced glaucoma, dislocated lens, or Morgagnon cataract, it is little rare, and lens-induced uveitis. Commonly what we do are, we intervene mainly when there is a visual acuity is not improving with refractive correction, and the remaining part goes to the retinal surgeon. We don't have to do anything, we just have to refer the patient to the retinal specialist. So in my experience, it was mainly a visual acuity loss, and not able to correct them, give them refractive correction was the main indication for surgery. Now coming to the significant subluxations where the vision is compromised as well as the binocularity is lost. Like here you can see this child came at in 2010. We have a 15-year follow-up now. Had a subluxation in the right eye, and the vision was only half by 60. Left eye, a mild subluxation, the vision was okay. And you can see it underwent a lens removal followed by a iris claw later. And almost 15 years of follow-up, the child has come with a 624 vision in the right eye and 6/6 in the left eye, which is decent vision in such a situation. So what are the things that you can do when you have a significant subluxation? An anterior segment surgeon will always be interested to keep the bag of the bag intact if possible, and also not to disturb the vitreous much. That would be our aim, but it may not be possible in all cases. This case, you can see it is a significant subluxation, but still I was thinking, I always try to do a rhexis in all these cases, and I could get away with the rhexis because the rest of the zonules were quite strong, and the rhexis should be of adequate size, and only then you can put in an eye also. There's no point in putting a very small rhexis, and it should not reach the edges also. So here you don't know the size of the lens, so putting in a CTR is not safe in such cases. So you can get away with CT segments, and also you can do the aspiration of the lens from the bag itself. Try not to put it into the vitreous, try not to disturb the vitreous. That is what you should do. And here, even after aspiration, you can see the bag is more or less stable. stable, and I've not gone for a CTR because I'm not sure whether the bag is of adequate size. So these CT segments are very good ones, like you get it in 9mm and 6mm size, and you can fixate those bags. And next problem is which IOL to put. That is a very big issue in these cases, because IOL power calculation may not be correct, especially when you do IOL power in a subluxated lens. Axial length may not be correct, and you can't put in just guessing and putting an IOL is also not safe. So it will be ideal to wait for a while, do the next procedure in 1 week itself before the bag collapses. And here you can see the child underwent. You have to deal with the posterior capsule also. So after 2 days, I did a secondary posterior capsular rhexis, and the next day we checked the IOL power using the IOL master, and we could get the power, and a secondary rhexis is being done here. Usually we do a PPC. So here you can see the segment there, and IOL was put in the bag. I put a 3-piece IOL. There's no question of putting it in the sulcus in such cases. So 3-piece IOL, the main aim is so that the haptics are, it's easier to deal with the haptics even if the bag is a little small. And also it would be ideal to see the fundus in the OT itself, to see the periphery of the fundus, and if any treatable lesions are there, it's ideal, it would be better to treat them before you put in the IOL. And child has been doing well for almost 1 year, more than 1 year now follow-up. But in cases like this, you can see the lens is just hanging from a stalk. So there's no pointing, and there is also microspherophakia. You cannot think of putting a segment or ring or anything in these cases. It's just to remove the IOL in such cases. You can't have too much of expectations. So here it just comes out easily. Only sometimes these zonules can be strong, but here you can see it is easily coming out. And now you can see it's a small lens, and you can think of putting in a secondary IOL later. So what are the secondary intraocular lens options you have? So iris claw IOLs are actually, it is a little blind procedure, but still it is a very easy and not easy, but it's less time consuming procedure, and many of them do well, but you're not sure in all cases. Like here you can see that IOL is introduced in the anterior chamber, and the pupil has to be of adequate size. Only then you can think of an iris claw lens, and you are enclavating the haptics. But I used to get very good results, but once bitten, twice shy. I had 2 cases of Marfan's who develop an atrophy of the iris at the enclavated site and dislodging of one haptic, and that is a very traumatic experience. So after that I am quite shaky, and I don't feel like putting iris claw in children. So nowadays I plan to do scleral fixation in all these cases. Now coming to the sutured scleral fixation IOLs, which we were practicing earlier before we had these 3-piece glued IOLs. So sutured scleral fixation IOLs we have been doing quite long back. Now we are not doing, so I don't have the videos of that. And you can see this is a child of 10 years of follow-up, doing well, but you can see so much of pseudo-phacodonosis appears here. You can see as the child moves sideways, an optic capture is happening, but stable vision is there, but still it is also a blind procedure where you are not seeing what is happening to the sutures, and you have that special scleral lenses, scleral fixation lenses, which we were using earlier. So now, it is mainly the glued IOL, and glued IOL gives really good results, and also the whole procedure is little more easier, and stability of the lens is really good, like not much of pseudo-phacodonosis. Only thing, the procedure you have to be very meticulous in the proper centration of the IOL, because little bit of decentration can be difficult, and any vitreous has to be tackled. It is more difficult in vitrectomized eyes. When you are just doing a lens removal and putting it as a secondary procedure, it's much more easier. And proper centration is very important. I still do with a scleral flap, which I feel is more comfortable for me and gives a proper closure of these exposed haptics. So the greatest issue in glued IOLs is you are externalizing your haptics, so you have to be very careful with that. You have to counsel the parents as to any problem, any pain, you have to come, because you never know whether they'll have eye rubbing, trauma and all those conditions. So here a 3-piece lens is being introduced, and you can see the engripping forceps is used to retrieve the leading haptic, and these small tips you get from your retina colleagues, like this I got from Divya, how to put in a small scleral piece so that it won't go back, and you don't need an assistant to hold the haptic when you are putting in the trailing haptic. And now I'm just introducing the trailing haptic, and it has to be exactly diagonally opposite, otherwise your centration won't be good. And gluing the wound as well as the conjunctiva gives so much comfort post-operatively. So this is one procedure I've been sticking to for the past few years now, because the results are quite good. Only thing, you have to be very careful in vitrectomized eyes that bleed should not go into the vitreous cavity, because once bleed goes, secondary glaucoma and issues are really painful, especially in a child. Examination of intraocular pressure, all these things are very difficult. So have a good retina follow-up as well as a pre-retina evaluation before you go for all these procedures, because all these are done as lifelong procedures and we can't be changing all these IOLs. So what next is the post-operative care. That is more important. Especially they come to the pediatric part, like wound and IOL related follow-ups, which is extremely important. Like you should always be sure that the haptic is not exposed, and you can have myopic shifts in these children and do recurrent refractions and give glasses. And any acute emergencies, always counsel the parents that if you have any pain or anything, just come to us, and immediately you have to intervene in such cases. So thank you for your patient viewing.
Thank you, Dr. Meena, for that wonderful talk. So I think in your hands now, your preferred technique for the IOL is glued IOLs. Yes. Than the iris fixation.
Iris claw, I told you, no, I'm afraid of that atrophy that can happen later, which is not in your control. You can do an iris claw, but if they come after 2 years with such problems, it is really painful. So I prefer the glued IOLs.
And I think the important message what she mentioned was like, because when their vision becomes normal, the children actually tend to lose follow-up. So when they lost to follow-up, and then when they develop something like a haptic exposure, the risk of endophthalmitis and all those things are very high. So it is very important to insist on that follow-up thing. Yes, sir.
Thank you. That was a nice lecture.
Thank you.
And few not questions, but just what's your take on what are the distance at which you make the scleral flap? Because in adult versus pediatric patients, the past one may be different.
Yeah.
So that is one. Second, you said put some scleral pads so that the other haptic doesn't go in, because you know, in all these kids that is a very scary thing, because eye globe suddenly collapses and the haptic goes in. That is the second query. How you do that? And third, is there any cutoff for your scleral fixated IOLs? Because at RP center, we used to do it even in 2-year, 3-year kids. But now we have realized in this case, the sclera is very thin. So now we wait till at least 5 to 6 years. Then only we go for scleral fixated IOLs. And last, you are perfect. Even I don't do a iris fixated IOL, because all this ectopia lentis patient, they have dilator muscle atrophy. So by enclaving, you may further aggravate that. So that's a very valid point that you made.
So earlier years you are little ignorant, no, but you'll be more brave. But when you get patients coming back to you, only then you start thinking about it. So I use the guarded blade. That was one thing that gives you some confidence that it won't go too deep. And only 0.5 to just beyond the gray area, I put in the needle. And the flap, usually I don't have a problem with the flap. The centration is very important. It has to be diagonally opposite. That is more important. And the younger stage, I used to do it at 3 years and all earlier. But as you said, now I'm putting a cutoff of 4 to 5 years. And many a time unilateral cases come to you late also. So usually the cutoff is now like 4 to 5 years. And most of them do well. That's all.